Hi, I'm Tracie Ibrahim. Welcome to this NOCD Q&A. So excited to have people here today to join me and learn a little bit about my journey with OCD, to learn a lot about what NOCD has to offer, and also to answer some questions that come up for people who are watching. So welcome. Um, just to sort of get started, if anyone wants to sort of introduce themselves in terms of, you want to put in the chat where you're from, or something along those lines. However, if you have questions, there is a Q&A function at the bottom of your Zoom, and that is where you will actually be entering questions. So just letting you know that. So I'm Tracie Ibrahim. As I said, I am a therapist of 20-ish years, probably more than that. I try not to add sometimes. It's a long time. Makes me feel old. And I have had OCD for, I'll say this, over 45 years. That's right, more than 45 years. And I was born and raised in California, and I have been living in Maine for the last 6 years. So one coast to the other. I do therapy for no CD. I see people in California and Maine. That's where I'm licensed. And in terms of what else I do for no CD, I also am the chief compliance officer, and I run our support group program, which we will be talking about a little bit later. Oh, I love that. See that? We've got people all over the place, even as far as Sweden. Yay. Fun fact. I am married to somebody who was born in Sweden, and jag talar svenska. So just so you know, I can speak a little bit of Swedish, so that's kind of cool. I love it. We've got people from all over the place. Welcome, welcome. So I just wanted to start off by sharing a little bit, letting people know just a little bit about my story and how I got to know CD. Oh, Canada. Woohoo. My story starts with OCD when I was 4. I'm going to give you a very high level overview, but nobody really knew I had it. It was mostly mental compulsions, magical thinking, trying to keep my family alive with weird magical rituals, counting, lots of counting. In elementary school, I was counting ceiling tiles and telephone poles and all kinds of things. And then later on, it started to morph a little bit. I moved into some contamination OCD, lots of fears around invisible poop germs, actually. That's my arch nemesis, or invisible poop germs. There were other things, but it's mostly that. And then as I was getting a little bit older, um, when I was 10 years old, 10 and a half to be very specific, a more taboo theme actually entered my life when I went in for a psychiatric evaluation. Just had some normal sort of family problems going on. And somebody asked me if I'd ever thought of harming myself during this evaluation. And I had not thought of that before, but this made me think about it. And next thing I knew, I was put into a psychiatric hospital for children and adolescents. So this goes hand in hand with why I ended up at NOCD, and why I will talk more about the absolute importance of getting evidence-based care and assessments and treatment with people who know what they're talking about. So um, a little bit more about that. So I was in a psychiatric hospital, and some people in there truly were actually suicidal. Others were not, but I was told that I was. So it became very confusing at 10 and a half. I ended up being in that hospital for 6 months because every time they would ask me, have you thought of harming yourself or how to do it? I would say yes, because that's all I could think about at this point. I was locked up. You said that I was a harm to myself. So Fast forward a little bit of time, I'm about 12 years old, and when I was, um, at home one day, I started getting thoughts that were intrusive. Now I know that they're intrusive harm OCD thoughts, but think thoughts that I was going to harm my father. I was going to actually kill my father, is what I thought. And I had intrusive images and urges and feelings and all these things going on. And I didn't know that's what it was, obviously. So I would hide in my bedroom and not want to come out, not want to walk by him when I was having those intrusions. And of course, through all of this, I still had contamination and suicidal OCD thoughts, but nobody had diagnosed it properly yet. So this continued on. Um, Fast forward 9 years. I went through 9 years of being in different hospitals. I was in almost 30. I was in 29 facilities where every single time the therapist, the psychiatrist, just they were not able to understand that these were all OCD symptoms, or how to tell the difference, or even what OCD was. So I was given the wrong diagnoses, wrong treatments, wrong medications. Everything was just wrong. Lots of damage done. We do know that the average person takes about 13 to 17 years to find the right treatment. A lot of things out there say evidence-based treatment or treatment specialist for OCD. And those are just words. You got to back that up with some facts. And I know that there's a lot of fast fix things out there. There's a lot of things out there like, hey, come to my weekend seminar and solve your OCD forever. That doesn't exist. I was actually all the way into becoming a therapist. And I was new as a therapist. Everything I had learned about what OCD was and how to treat it was wrong, which of course I didn't know, like so many other people had done to me earlier, right? But I thought I knew, and I did not know. I did not know how to treat it properly. My people with OCD were not getting better when I was using these techniques. This is actually a huge area of concern. Most graduate schools for people doing therapy and psychiatry don't actually cover what OCD is and the many ways it can come out, and how to properly treat it with evidence-based practices. The gold standard being exposure response prevention, which is what we use at NOCD. So one day I was like, my OCD, my symptoms were out of control. My people I was treating weren't getting better. So I went online and I Googled one day, what is the most effective treatment for OCD? And this exposure response prevention came up, and I had never heard of it. And so I was like, started reading about it. I went out, I learned it. And I got some of that myself and found out it worked. And I was like, whoa, that's weird. It's like opposite of everything that I've ever would think. So as my symptoms started getting better, I was already 31, 32 years old. Mind you, I've been since age 4, not being treated or assessed or diagnosed properly. Really fun fact, my mom was a therapist. She still is. And she didn't know any of these things either. So it doesn't even matter if you know somebody who is a therapist who's living with you, they may not know either. So yeah, it took a long time to get to the right place. I have been able to stay well for 20 plus years just using ERP. There are a number of things that can help people with OCD, such as combination treatments of the right medication and the right treatment. But what research does show, medication by itself will not teach you how to manage your OCD. Medication and ERP treatment together can do that if you're with somebody who knows the right medication and the right dose, and if those work for you. So I happen to be somebody who medications don't work for me. I use 100% ERP to stay well. I use some ACT or some acceptance commitment therapy, which is really just allowing my values to help guide my choices instead of fears and compulsions and things of that nature. So, what really drove me to this work is my own experience really in having taboo themes of OCD and people not recognizing them and not understanding how to treat them properly. So, in my own journey to help people get to know what these things are and know the truths about them, I've done a number of things. Like I came to work at NOCD 4 years ago. For about 3.5 years or so, I've had a social media on Instagram called Taboo Tracie that very specifically talks just about OCD facts and treatment and all of those types of things so that people can start to understand that OCD is a lot more than you think it is. Um, and that there's a way to get a manage your symptoms. It's not curable, but you can live with it. So just to give you an example, I've had a billion different intrusive thoughts and images, on any given day, just a lot of the day, uh, but you wouldn't know it by looking at me because I'm not compulsing, I'm not believing them, I'm not freaking out. I'm just really saying, hey, I can sit in the uncertainty of all of these things sort of happening in the background. So I think of my OCD now more as background noise. Um, but it is really, really, really important to note you will not find your answers by asking other people, what medication were you on? What worked for you? We are all different. We have different chemical makeups. And at the end of the day, we behave our way into managing OCD. So that's really important to note um, because that's what we treat. That's what we teach here at NOCD. So how we can make sure that our program at NOCD is effective, and we do have people who can provide proper assessments and treatment right from the very, very beginning. NOCD starts with a very intensive, several week program in which we train. This is what OCD is. This is how to treat it. These are different ways that it can show up. And that teaching and learning and support never ends for our therapists. We offer all throughout the week people like me who are experts in treating OCD. The therapists can come by and ask us questions, and we can help them get through those things and understand how to best approach those things as they are becoming specialists of their own. So that's the first thing that we do. The other thing that we do is we check our therapist's work to make sure what they're doing is effective and fabulous. So, like I run the risk and compliance department. We do audits on our therapists to make sure that the care they're providing is the care that we meets our standards and make sure that you get the highest quality of care. Um, and what's really the best thing about that is that enables our therapists to be able to support our members in the absolute best way possible. So we have a lot of different things built into our NOCD program. A lot of people don't know this, but for instance, we have this community. You obviously found this because you found our community of like-minded people and people who are struggling, and it's nice to not feel so isolated. OCD is a very isolating disorder. Your fears often make you avoid and stay away from a lot of things that you love or cared about. And so it's important to feel connected and feel less alone. And one of the ways that we accomplish that is we have a free support group program just for our members at NOCD who are in active therapy. Right now, we offer right around 30 support groups a week, different topics, different specialty areas. I run two of them actually, on specifically taboo OCD themes. And I love it because those groups have been running the longest, actually. One of them has been running as long as I've been here. And the taboo groups are actually larger in attendance than any other group, which helps those people with those more difficult themes to discuss realize they're not alone. You're like, look at this. I have all these people in here who are dealing with the same thing, whether it's pedophilic OCD or suicidal or homicidal OCD, or whether this is about your kids or it's about your loved ones or it's about your pet or it's about any number of things. A lot of people think, hey, like I'm the only one with this. Somebody recently came up to me and messaged me and said, hey, I have never heard of anyone else with this, but I have intrusive thoughts about cannibalism. And I'm like, oh, I hear about that all the time. So just so you know, our therapists are not going to be shocked or freaked out or, you know, uh, in awe of what you're saying. We know what to do. And we know how to help you um, manage through those sorts of discomfort. So I will say this about ERP. The way that ERP is working is your symptoms get a little bit worse before they get better. And that's because we're challenging it. We're challenging our fears that, hey, I can face my fears or sit with the discomfort of those and find out that they're actually not even true. Or maybe they're possible, maybe they're not possible. But it's important to note this. Every theme of OCD is actually the same OCD. Nobody gets diagnosed with a kind of OCD, like you have this kind of OCD. We just diagnose OCD and we give you the tools to make it manageable. So we cannot do the work for you. We start by doing the work with you and filling your toolbox so that you can take it out in the world, and no matter what theme comes up, you can utilize that. So that is something that I think is very, very important to note. So all throughout your NOCD member journey, there are a lot of different points that we have where you can get support. We have a member advocate team where these are people who've been through OCD treatment before, and they're on the side where they are more on a wellness side of things. And the good part about that is they're people who you can reach out to, and maybe you're struggling a little bit. Maybe you're like, gosh, this is really hard. What did you do to try to stay on top of your difficulties going through ERP or something like that? And they can help you, and they're there to support you. Like I said, we have different support groups. We've got managing depression and OCD. We've got things like the LGBTQIA plus community, a nice group just for people to go and talk about that. We have autism and OCD group for people who are neurodivergent. We have a lot of different things, self-compassion group. We've got managing mental compulsions group. We have a lot of different groups that people find very helpful as you are going throughout your NOCD journey. And then on top of all of that, we also offer something kind of unique here. We have a secure messaging system between you and your therapist. So for instance, my members, maybe I gave them some homework to do, or maybe they're going through a little tough time and they want to message me and say, hey, can you remind me, what my tools were that I was supposed to use when I do this? And I can answer them right there. So they don't have to wait till that next session to get that answer. So our messaging platform, like I said, is secure. And it's always available. And then on top of that, we also have so many other great resources for our members at any given time. Things like that you can attend to learn more about different types of workshops, all different kinds of things. So I think that's pretty fabulous. And I know that it can be hard reaching out, especially for the first time, or if you've reached out before and you found out that actually you got the wrong treatment, or maybe it wasn't helpful. I've had a number of people come to me and say, I've tried ERP therapy and I didn't like it or it didn't work for me. And again, I don't know who they did it with. I don't know what happened. I don't know the situation, but let's give it a shot. And most of the time, it's people who didn't really know what they were doing when they were working with somebody. So that's why at NOCD we have very high standards to make sure that people are getting the right treatment. So I'm going to move on to some questions now. So let's see what we've got here. Do I have knowledge about TMS procedures for OCD? Yes, actually. I'm not going to talk extensively about it, but there are different sort of levels of TMS. It is deep TMS that is has some efficacy research supporting to help decrease some OCD symptoms. I've had a number of people that have gone through it. It is not, it doesn't replace therapy. It's like anything else. It's how, sometimes it can be helpful, sometimes it's not helpful. Everybody's different. So again, it's sort of that uncertainty around that. But it still requires you to be able to know how to behave when these intrusions hit you. So there is nothing that will wipe out OCD for you or go, now you don't need treatment because we made you not care about it. Like that doesn't exist in any form, just so people know. Does OCD affect your brain? Does it mean your brain is damaged? Great question. No, your brain is not damaged. I'll give you a very high level sort of overview of OCD in your brain. There are a couple of areas involved, a lot of them, your basal ganglia, your amygdala, there's some various areas. But basically, it's a false alarm going off in your brain. It's kind of a two-part problem. Let's start with this. When a real thing happens, right now, if I'm sitting here and I hear somebody scream and glass breaking, I am hardwired, like all humans, to respond appropriately and help navigate this emergency. So you get adrenaline, you get serotonin, you get a lot of different chemicals that come down so that you can jump up and that you can react quickly, right, to this emergency. What happens with people with OCD is that exact same part of your brain that sets off that alarm to say, go figure out that emergency. It goes off, but there is not an emergency. So imagine it's going off and it's like, oh no, you're attracted to people you don't think you are. Oh no, you're going to harm somebody. Oh no, that's so dirty. You're going to get a disease. Oh no, you're dying of a heart attack, right? And so this false alarm goes off with this message. And so people with OCD, they don't know 100% what causes OCD, but they know some of the mechanisms from brain scans. So this false alarm goes off, and we have like a filter system. Basically, you're supposed to have a filter system that filters out the things that are illogical. People with OCD their filter tends to be less operational, doesn't work as well as it should. So a lot of those thoughts make it through to you, along with the chemicals that make it feel real. So that's what OCD is. You're not broken per se. There's nothing damaged per se. It's just not behaving the way it's supposed to. So we have to learn how to have our alarm go off, make it feel real, but then not react to it. That's the most important thing. All right. You would like to do as many sessions per week. Okay, so yeah, I can talk about that. So typically when we start, we schedule people at twice a week, 1 hour and 1 hour. We start with some assessments, sessions, and then we teach you more about OCD and the ERP process, and we move on from there. Sometimes people have a lot going on and they need more than 2 sessions a week, as long as your insurance or you are able to cover that, and then we certainly do offer that. We are covered by the vast majority of insurances, not 100% yet, but we're getting there. And then over time, as you're getting better, we start to cut back on how many sessions that you are seeing. So you would reach out to care@nocdhelp.com, or you could just go right on our website and you could click for the free kind of questions with our care team, and our care team could tell you who's available, who's not available, to see you at a particular frequency if you were interested. They can also talk about your insurance coverage and whatnot. So that's also important. Um, can I talk about DPDR and OCD? Yes. So DPDR, it's depersonalization or derealization. I have to say this first because it's important. This is a concept that people on Reddit and TikTok just sort of went nuts with. So a lot of people with OCD who are compulsively researching are going, "Oh no, what if I have DPD or DR or both? And what if I freak out? And what if this happens? And what if and what if?" So first of all, I'm not worried about depersonalization or derealization. I'm not worried about that with OCD. I'm not worried about whether it's happening or not. I'm not worrying about if it happens, will other things happen that are bad. That's just part of people with OCD kind of freaking out. What if this happens? Um, we all go into this sort of checkout, spacey sort of thing, and we could call it that. Um, I'll give you an example. When you're driving and every once in a while you realize that like your eyes were no longer seeing the road and you were like imagining something and you go, "How did I get home?" While also totally feel like I was like in a different world. It's not very different than that. And the average person does that about 12 times a day. Some research shows who don't even have OCD. It's not a problem. It's not a concern. I don't worry about it. My best recommendation would be don't Google it anymore because it will become scary and confusing. Do I know what the right medication for OCD would be? Great question. So I can't tell a person what's going to work for them. That's out of my scope of practice. But if you're interested in knowing about medications that have been found to be helpful and the doses of those, you could actually go into Google and you could go to the IOCDF, the International OCD Foundation. If you just Google IOCDF and then meds, a link comes up and that you can find more information about some helpful medications there. And again, what helps one person isn't necessarily going to help the next person. And there's no perfect answer. And again, medication is an assistant, but you still actually have to find out yourself what works, or you might be like me, medications don't work. So that is something that is important to know. Let's see. What is the best way to get someone to initiate getting help? Yes, adult son. Promise to reach out for help. Um, yes, great question. You know, you can't really drag somebody in to get treated for anything that they're not interested in being treated for. That's the unfortunate part. I really feel for you on this one. 2 of my 3 children have OCD. They're all adults. Um, and one of my kids is treated, one of my kids is not treated. And that's with me being an ERP therapist. So what I sort of say is, listen, I'm not going to do things that make your OCD worse. I'm not going to take part in accommodating your OCD, but what I will do is make sure that you get to the right OCD treatment if and when you're willing. So, yeah, that can be really a complicated situation. It works the same in addictions. If somebody doesn't want to get sober, you really can't just get somebody sober who doesn't want to become sober. You also can't get somebody to agree to stop doing compulsions if they don't want to, especially as an adult. When they're children, you can drag them in against their will. And even then, sometimes they're not going to be willing to do it. But yeah, that's a hard situation. I would just keep reminding your adult child that you could do something, that you're willing to help when they're ready and if they're ready. All right. What can I do if right now one of my worst compulsions happens when I'm reading any text? When I start to read, a lot of thoughts come to my mind. OCD says I have to reread. Oh, yes, again and again until it feels perfect. And you don't think any, yes. Yep. So you're talking about just right OCD. You have to do it until it feels just right. I struggled with that theme when I was in college, actually. Took a long time because I'd be like, no, that wasn't right. Wait, I didn't absorb it. Wait. Um, so that really is something that a therapist would need to work on with you and be able to put some exposures together for you. Um, but yeah, that I totally get that. I also had one where I would have to read everything forward and then backward and then forward again, which it's exhausting. The short answer to that is don't do it, which sounds easy and obvious, but you really need to get through some ERP therapy to sort of learn more about that and how to navigate that. So even now, like I'll be like, my brain is like, read that again. And I'm like, no, I'm not going to do that. I'm going to sit with the discomfort that it didn't feel right, or I didn't read it forward and backward and forward, or all of those kinds of things. Um, I was just diagnosed with OCD. Uh, What a cult person cause. Oh, yep. So I mean, anything traumatic can attach to OCD. OCD can attach to anything, put it that way. It attacks things that we value and the things that we care about. Um, and so sometimes it's how you were raised. Sometimes, like you're saying, you're raised with a lot of scary thoughts, and whatnot. So yeah, I mean, there are things that can, environmental things that can make OCD worse. My grandmother had very significant contamination OCD and definitely raised me that way with her rituals as being, this is the safe way to live. So it took me quite a while to sort of get my brain around like, wow, I actually don't have to do that. I don't have to wash each vegetable 12 times and soak it and do a whole thing. And we still live, So yeah, we can learn sort of more compulsions from other people or from our experiences. Does NOCD work in Puerto Rico? That is a great question. If you reach out to our care team, they can let you know what we do offer or not in Puerto Rico. Right now, I know that we are in all of the United States, the UK, Canada, Australia, and even in a handful of other countries. So yes, definitely please reach out to our care team. Can someone have a reverse OCD? If OCD is being compulsive, what if you struggle to get anything done? Oh, I like that. There's no such thing as a reverse OCD, so I should probably start with that. So if you struggle to get anything done, it might just be because you're too caught up in the rituals of the compulsions. It could also be because depression and it's hard to get motivated. Hard to really tell, but it's important to get a proper evaluation so that you can sort of find out more about that and how that's showing up for you. But no, there's not like reverse OCD. So sometimes what people don't realize is some compulsions include avoidance. Avoidance is a compulsion. So not reading certain things, staying away from certain things, struggling to get things done because you can't do them in the most compulsive way that feels the best, or it's too exhausting. All of that would still be just standard OCD. Excuse me. What is TMS? It's transcranial magnetic stimulation. It's a magnetic stimulation in a specific part of your brain. How do you do ERP for a theme like relationship OCD, where intrusive thoughts that are not extreme but rooted in real possibilities? Great question. We do ERP the same for all OCD presentations. Like what I was talking about earlier, there's only one OCD, and the only reason we even have themes is to describe how your OCD is showing up right now. But once you learn the ERP tools, they go across everything. So there are things like real event OCD, something really happened, false memory OCD, existential OCD, where it could have a little bit of possibility. So for instance, with relationship OCD, a lot of the questions that get asked are things like, is this the right relationship for me? How will I know if this is going to last forever? How do I know if this person's cheating? How do I know if, 500,000 other questions. And the answer is we treat those all with ERP. And again, it's very specific to each person and how their fears are coming up within their theme. And so a specialized therapist would help you to navigate that situation. Same with religious OCD, spiritual stuff, all of those kinds of things. So people are seeking certainty. Everybody would love to have certainty. Who wouldn't want certainty? That means for sure, I know how this is going to turn out. I know that it's going to be okay. I know that everything's going to be amazing. That doesn't exist in anybody's life, in most areas of life, if we're honest with ourselves, right? Like, I could ask you right now, what do you know about how much rent you're going to pay in 3 years? You don't know that. What do you know about, how long will you live? What pet will you have in 12 years from now? Will you even be around 12 years from now? There's so many uncertainties, and people with anxiety and also people without anxiety, the uncertainty gives them anxiety. Like, I don't like to not know, I like to plan. So when it comes to things like spirituality, religious, scrupulosity, OCD, it's like any other theme, right? I brought this up earlier with somebody, but if I went to a religious leader, one from every single different religion, and I asked them, what is the right way? What is the way that I should do this? What is the correct thing? They would all have different answers, right? And they would all be taking a leap of faith, that their faith is the one that is the right one, or they're doing it the right way. So there are a lot of things that we do that actually require us to take a leap of faith. And most existential and religious types of things, that's how it goes. I mean, that's how it goes with most things, right? So yeah, so that's how we would do that. I don't go out a lot, but when I do, I'm in public places. Keeps telling me these thoughts all about objects. People are dirty, contaminated on the floor, contaminated diseases, for example. Yes, classic contamination OCD. And again, let's look at how similar that is to my last answer. Sure, certain things might be out there. There might be germs, there might be illnesses. Some of it might not be true. For instance, like if it's something that you can only get through blood transferring from one person to another person, I'm not going to get that if you cough on me and there's no blood and I don't inhale your blood, right? So, but OCD will go, but what if? But what if you touch that and then you put it in your mouth and you forgot or you don't know and everything's dirty? Contamination, again, we sort of have to go with our therapy and having somebody work with you on how, what that would look like and how to work this out with you. But I used to not travel because I feared all the germs that were on everything. And I realized that I was missing out on a lot of fun opportunities. And so I started traveling and accepting the possibility that maybe I'm going to get sick. I have traveled and gotten sick. I've also traveled and not gotten sick. I've also touched things that could have been dirty and could have had contamination, and I don't know. And so really, we teach you to sort of live by your values as opposed to always avoiding because of fears. All right, let's see. I've tried ERP, made my symptoms worse, so I stopped. I'm really worried about ERP doing more harm than good. What should I expect in the course of treatment? How long should I wait before symptoms get better? Great question. So in the beginning, when we start facing our fears are going to come back and be like, are you sure? Are you sure? Are you sure? And we're not used to challenging our OCD. We're used to going along with it and compulsing, so it can feel scary at first. And a lot of people say, that's it, this is doing harm. I have to sit with this possibility of harm, or possibility of this, or possibility of that. And the truth is that I've never seen ERP do harm to anybody. And that the most important thing you can do is take those tools you learn in therapy and apply them at home, because you're only in therapy for a very brief time, right? Maybe you're in therapy for an hour, but it's 24 hours in a day. What are you doing with all the rest of that time is what really matters. So you cannot come into a session and have a therapist do all the work sort of like for you, and then you go out and you're like, okay, I don't have symptoms. Like, it doesn't work that way. So I haven't been in therapy in many, 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 many years. And the way I stay well is holding myself accountable to therapy and to doing the things that I need to do on a day-to-day basis. So I build exposures in, and I do all those sorts of things. ERP itself will not make your symptoms worse. If you do response prevention, which is not compulsing, that is actually the only way to make your OCD symptoms start to get a little bit quieter. And that's why ERP is so important. And I typically find that treatment time varies. How long are you going to be in treatment? Really, 100% depends on how much and how quickly and how ready you are to really do the work that it takes. I'm going to turn on a light real quick because it's about to get dark here. Okay. So I've the fastest I've ever had somebody get ready. Get a lot better. I'm not even going to tell you because it was so short that it was like unreasonable. It's just a few weeks. But on average, we see people right around the 12-week mark start to get a significant decrease in symptoms. That being said, some people are so afraid and just, they just want to dip their toe into treatment. And then, of course, it's going to take a little bit longer, just like anything else. Think about it like the gym. If you want to have, I don't know, giant muscles, you can't go to the gym once in a while. You got to go all the time, and you've got to work on it and keep going. And if you give up and you stop, those muscles are going to go away. If you don't go long enough and you don't apply yourself enough, you're not going to build enough muscle. So this ERP is like building muscle or building skills to help you manage your OCD. Can I recommend some books that might be helpful in addition to therapy? Yes. I'm very bad at like general titles and who wrote them. I did put some on my Instagram page, but yeah, there are a handful of books. I will say one thing that I'm very passionate about, Kimberly Quinlan has a workbook called Self-Compassion with OCD Workbook. That's not about how to solve OCD, but it's how to be nice to yourself and have self-compassion when you're going through OCD, especially when you have a lot of disturbing thoughts and you feel like I might be a bad person or something along those lines. And we are not bad people. In fact, we are just people, and we don't make up these thoughts. So that's just really important. Can you have only one theme of OCD and never any others? Yeah, absolutely. I've treated people who just have one theme. It's common to have one theme. It's common to have multiple themes. It's common for themes to switch. Sometimes you have multiple going on at once, like I do. And I have some that come and go. I call my contamination OCD my ride or die because it's been there for the longest. It just doesn't go away. But I manage it very well using my ERP skills. Let's see. My OCD has changed in the last few months, and one new thing I noticed is that OCD creates false memories in my mind, and then I don't remember things correctly. Great, 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 great. I'm really glad that you brought that up. So false memory OCD, again, all OCD is OCD, but Where we can get false memories tends to be more often when we've ruminated or done too many compulsions around trying to figure something out. So maybe it's a real event. Maybe you were backpacking, I don't know. You're on a backpacking camping trip, and you can't remember because maybe you were drinking, or maybe you were tired, or maybe you're like, oh no, I don't know what was going on. And you think, gosh, did I do something wrong, or did I do a bad thing? Did I cause harm? Did something happen? And you're trying to remember. And this trying to remember, which is you going back and mentally reviewing over and over, retracing the steps. Maybe you're calling people to ask, did you see me? Was I there all night? Did I leave my tent? All of those things are compulsions, by the way. And the more compulsions we do to try to figure it out, our very logical brains now say, oh my gosh, wait a minute. This is weird that you keep asking me the same questions I don't have an answer for. Let me fill in the blank for you. And that's usually where false memory OCD comes in. We have people that are like, you know what? I think I cheated. I think I cheated on my partner, but I don't remember, but it's entirely possible. And you can totally end up creating false memories of doing this thing. So the more you compulsively try to figure out something or try to solve it for certainty, the more confused you get, actually, the more distressed you get, actually, and sometimes you create false memories. So again, that's where you have to sit with, I always ask people, do you have a time machine? No, you're not going to go back in time to figure that out. Did you record those moments? No. Sounds like we're going to sit with, I don't know what happened at that time. I'm going to leave it alone, and I'm going to be here in this present moment because I cannot solve that. All right. I have OCD, don't have too much insurance coverage. So all of our therapy is telehealth. It is online. I encourage you to check with our care team to see if we are in network with your insurance, and if not, what other types of options we might have. Is OCD an anxiety disorder? Great question. Many, many years it was in the Diagnostic and Statistical Manual, or DSM, which is how we diagnose people. It was in with anxiety disorders. For some reason, in this last edition, they took it out, which doesn't make any sense. I'm sure they'll put it back in. But yes, it really is an anxiety disorder. It really is based on anxiety. And fun fact, at NOCD, we treat OCD and all of the anxiety disorders that are related, anything, social anxiety, panic disorder. I won't even go generalized anxiety. There's a million different forms of anxiety disorders. They're all treatable with ERP. So that's what I love about ERP. You learn it, and now you have the skills to manage multiple things. Is it normal that my OCD is the most intrusive when I'm thinking or doing anything I love? Yep. Hobbies, families, loved ones. Yes, absolutely. OCD is always attacking things we care about. So I've actually taken a very interesting take on how I manage my OCD with ERP. But if it wasn't bothering you about something you cared about, you wouldn't care, right? So imagine it was like, hey, I just want you to know, like, some adorable bunnies are going to come to your door. They're going to be soft and fluffy, and you'll have to pet them. Great. That sounds amazing, right? Or if it's like, hey, your worst enemy? Yeah. Well, they're moving across the country. Oh, great. I love that. That sounds fabulous. It's never that. It's always worst case scenarios, things you care about, things that bother you. That's absolutely what it is. So it's very important to realize that, because it always attacks things we value. It tends to be kids, family, loved ones. I've had it go against my parents. I've had it go against my children, myself, my pets, all of the things. So yes, very common. And so the way I look at that is if OCD is giving me terrible thoughts or images or feelings or urges about things I love, then I'm grateful. I'm like, hey, that proves I love them. Thanks for giving me those thoughts about that, harming them, or whatever other weird thoughts I'm getting. Is there an overlap between OCD and psychosis? When I experience DPDR, I'm scared of being psychotic. So that's just an entire theme of OCD. Am I losing my mind? No, there's nothing, no connections between OCD and psychosis. That is just a common theme of OCD. Am I losing my mind? What if I check out and I do terrible things? It's just not a thing. But even if I tell you that and I say with 100% certainty, this is not happening, your OCD will still come back and make you question it in 52 other different ways. So that's why we can't always say 100% this is the situation and now I feel good about it, and then OCD just goes to bed and never bothers you again. That doesn't happen. It will come up. It will keep coming up. So yeah, and NoCD has a lot of good blogs on different themes of OCD that come up, and that's one of them, just so you know. Is retroactive jealousy a form of relationship OCD? Yes, and ERP does work for it. I've treated it many times at NoCD, and even in the many years before I came to NoCD, retroactive jealousy can be a form of OCD, relationship OCD, absolutely. Can OCD cause depression? Great question. There are a lot of research studies, and yes, so OCD it sucks in a nutshell, and therefore it can make you feel depressed especially when you're in the throes of it, feeling like a bad person, feeling scared about the thoughts and things that are coming up. So it's very important to note at those times that yeah, absolutely. It can make depression can make you feel less motivated to do work on your OCD. So it goes back and forth. But research also shows that as you start to lift some of the OCD symptoms, depression tends to get better and vice versa. As your depression starts to get a little bit better, so do those things as well, such like your your OCD symptoms. So that's really important to note. So the most powerful way to shut down OCD is to do ERP. So yes, and I want to be very clear, when we say shut down OCD, we will always have OCD. We will always have symptoms, but the difference is whether you're in control or it's in control. When you're in control of your symptoms, you can live your value-based life and you can do the things you want. The goal is to learn how to live a full life while also having OCD. So the only reason why people find OCD to be so awful is it feels real, and then we react to it. And the more we react to it, the worse that it gets. And so we need to really be careful to make sure that we are not compulsing and doing those types of things. And then over time, the distress from OCD and how often it happens gets smaller and smaller and smaller, but it's still there. And it can still be a big flare up every now and then, especially you're sick, something's going on, things are happening, all that kind of stuff. So very important to note. Let's see. So the most powerful thing you can do is stop compulsing, by the way. So to not do, what else? Is it normal that OCD tries to get stronger at this precise moment? Almost sounds like OCD knows you're trying to get rid of it. Yeah, I mean, OCD is not a person or like a wizard, it's a broken alarm that sets off chemicals. But it certainly will attack things that you care about and be like, oh, okay, you know, we already have a habit. When I'm triggered, I compulse. When I'm triggered, I compulse. We're learning a new behavior. When I'm triggered, I don't compulse, and I learn that I can manage through that. So that's really the process that we teach and what it is that we're going through. How does one do ERP with relationship OCD? The same as we do it with all other themes. Again, your treatment plan is individual. It's about how it comes up for you specifically. So that's really important to note, that a therapist could help you sort of put those things together. But we help you sit with the fact that there are a lot of different things about relationships you can't be certain about, and help you learn ways to manage through that. Sexuality OCD. Aha. So you're talking about sexual orientation OCD. Same sort of thing, right? I could give you certainty, a certain answer, but it's not going to stick with you forever because OCD will still come back. So when OCD comes up in the form of sexual orientation OCD, am I gay? Am I bi? Am I not gay? Am I straight? Am I this? Am I all these different sorts of things? Again, it's attacking your values. It can't change who you are. It can't make us behave a certain way, but so this is a theme actually that I haven't gotten, and I have an idea on probably why. But if you think about this, if I were to be somebody who is attracted to, just say, like, other women, well, I would love that. I would enjoy that, and I would go after that. It wouldn't be distressing, right? Um, but if OCD comes in and it's like, hey, you're attracted to people that you didn't think you were attracted to. And I'm like, oh no, is this true? I have to figure it out. Oh my gosh, this feels scary. Did I get a feeling when I saw that girl? This happened, this happened, this happened, all that intrusive doubt. That's that's how we see sexual orientation OCD come up. Now, I could tell you, right. Um, you don't have to question most things in life that are certain. But OCD will make you even question the things that are certain, like who you're attracted to. So something sort of interesting um, to think about. Can you do ERP for intrusive thoughts? Like, do you even love your partner? Yes. Yes, you can. And any correlation between OCD and addiction? Okay, yeah, no. So I can't speak to supplements. Again, not a doctor, but no, I haven't seen any particular supplements solve OCD. Is there a correlation between OCD and addiction? Not that I'm aware of. However, if you're in an addictive process and you have OCD, they can definitely make it worse. And we will not do ERP with people who are in active addiction, because your brain is unable to learn what it needs to learn while sober. So all good, great questions. I hope that that was helpful. I hope that if you have more questions, you can come out. It's a free consultation with our care team. If you have more questions or information, we have a lot of blogs. Stay off Reddit. They don't have the answers. Glad you could all make it out today. Hope to see you maybe in one of my support groups.